All right, well, thank you for that great introduction, Tony, and thank you all for being here. I'm very honored to be able to present in front of such an esteemed audience and be the lead-off speaker of this year's seminar series. I'm also filled with pride and nostalgia about being able to present, particularly in the Stokes Auditorium. And the reason is because everything that Tony described, my career, the seeds of that career actually started at Children's Hospital 31 years ago, I think 1986 in the summer, where I, as a Penn undergraduate student, was a Joseph Stokes Summer Research Fellow. And I worked in the hematology lab that was led by Eli Schwartz, who went on to become the physician-in-chief here. And now he has his portrait on the wall right next to Dr. Koop, and next to Dr. Cohn. And actually, Dr. Schwartz was able to come in today, and I'd like to just dedicate this talk today to him and my other research mentor from that time, Morty Pons, who's still an active hematologist here. And I just want to dedicate the talk to them and recognize, their great role in my my career as it's become. So I'd like to just give them thank you very much. And actually, the results of that work, were these two descriptions of polymorphisms, and this took, the whole summer for me. And I understand, now with gene chips, you do 100,000 of these, in a day. But this was a lot of work back in 1986. So I always love talking in front of new audiences because new audiences haven't yet heard my mantra. You'll notice it's not dated nor attributed because it's more fun to ask who said it and when. If anyone wants to shout out some ideas. Because it kind of sounds like, we could be talking about, the introduction of HMOs in the 90s, or maybe, Medicaid or Medicare in the 60s, where we're really caring about, are we managing care well? But it's older than that. It's actually 1870, and the speaker was actually not a physician, but a nurse. So how many nurses from 1870 have you heard of? Florence Nightingale, exactly. So she was a Crimean-era nurse, but a very well-known health services researcher. And what's what's funny about this quote is when you think about the resources Florence had 150 years ago compared to now, we're much, much further along. But how much further are we at, being able to address the issues that are raised in this quote? And I guess the only word that really makes it seem old is the word mischief, right? We don't use the word mischief. What do we say? No. Well, in this context, it's fraud, right? Mischief is fraud. So anyway, so I'm here to talk about truth versus truthiness. So let's start with some definitions. So truth is defined in Merriam-Webster dictionary as the state of being the case, a fact, or the body of real things, events, and facts, actuality, things we know for sure. Truthiness, on the other hand, for those of you who watch Stephen Colbert, know that it's the word of the year for 2006. And it's the quality of preferring concepts that one wishes to be true rather than concepts or facts known to be true. Okay, and we could say, well, we're all scientists here. We know the truth. But I hope what you learned through this talk today is that sometimes our sense of the truth is biased by a little truthiness, what we feel in our gut to be true. And so I want you to be thinking about how do we know something is true, especially in medicine. So we have tools for capturing the truth, and I like to distinguish what your head thinks and what your heart thinks or wants to think. So a common one is, are men being overtreated or women being undertreated for heart disease? And you can look at the data and say, well, men get more invasive cardiac procedures than women, but does that mean they're being women being undertreated or men are overtreated? And then you can look at the overall rates of procedures in this country versus Canada and realize that men and women both get more procedures here than in Canada, so maybe both genders are getting overtreated in this country. Should all postmenopausal women use hormone replacement therapy? When I was starting out my career, it was a requirement. I was a bad doctor if I didn't prescribe HRT, hormone replacement therapy. Then suddenly I get sued for prescribing hormone replacement therapy because the Women's Health Initiative found that actually the cardioprotection was actually not only not present, it actually made things worse. And actually, in JAMA, just yesterday, we're reversing that. And suddenly, the new goings-on that's been picked up by the United States Preventative Task Force is there's no difference in mortality, cardiovascular or breast cancer mortality from HRT. So we can now prescribe it again. Yay! So again, it changes. Should all women between 40 and 50 receive mammograms? Okay. The United States Preventive Task Force says 50. The NCI and American Cancer Society say 40. And well, it's easy. Well, let's say 40, and we'll catch more women. But are we actually saving lives by doing that? We all know, or personally, or know of people who've had breast cancer, in their 40s, maybe even in their 30s. Why don't we start, doing mammograms in the 30s? And again, the difference between what our heart wants and what our head tells us we should be doing sometimes are in conflict. Another favorite of mine is, should medical care be a 24/7 operation? And you could say, yes, but have you ever been in the hospital at 3 a.m.? It's kind of different than being in the hospital at 3 p.m. You can't get all of the radiological services at 3 a.m. as you can at 3 p.m., at least not in my day. Maybe things are changing a little. So when you think about informatics and data analytics, how can good informatics methods lead you to the truth? But you also need to be humble and say, well, how many ways can informatics methods lead you astray of the truth? And what assumptions do you make about the validity of the data being processed? What assumptions do you make about the appropriate analyses? And have your assumptions in transforming raw data to an analytic data set introduced bias? And this is the main motivation for this talk. I've been to countless big data presentations about big data analytic methods. And they always start with a very neat data set where there's one record per patient and a lot of columns with a lot of putative risk factors of some outcome. You're trying to find, what characteristics predict readmission or predict sepsis or something like that. And invariably, the transformation of data that comes out of the EHR into that analytic set, I guarantee, has introduced bias. And then all of your big data analytics and all the fancy methods you're developing will, unfortunately, propagate that bias into the result. And I'm not saying it's all for naught. I am just saying that you need to be mindful of these biases in interpreting the results of your analyses. So what assumptions do you make about the appropriateness of the data for the truth you seek? And I'm sure none of you will ever say you've done this, but we all sort of do this. This is the classic cartoon where a guy is looking for his lost keys under the street lamp, and a policeman says, oh, you lost your keys. Where did you lose your key? Did you lose your keys here? He says, no, I lost it over there, but the light is better over here. Okay? You would never do that, right? But no, do you use data you have available to answer the questions you want to answer, and do you alter those questions you want to answer based on the data you have available? Okay? We do this. It happens. It doesn't invalidate the findings, but again, you need a little humility in interpreting the results, because otherwise you may put out something there as true that's not exactly true. Okay? What assumptions do you make about the interpretation of results? It's very easy with big data to find differences that are statistically significant. But are the results clinically meaningful? Do your results advance or alter conclusions made through other means? Early on, I found I was talking to a biomedical researcher who was sampling blood from the jugular vein in patients after a stroke, and they were doing proteomics, and they found that certain proteins that spilled into the jugular vein were predictive of poor functional outcomes. I said, that's really exciting. Are you measuring blood pressure and oxygen levels in the time period, when you're collecting that, that sample of blood for the protein? They said no. I said, well, how do you know the protein isn't just a marker of hypoxia and you didn't need your fancy proteomics, you just had to have a good pulse oximeter and track that data? So you can have a fancy test that's very accurate, but is it truly better than something that's existed for many years? Is there a threshold where your results change clinical decisions? I brought my umbrella here today, and I thought I was the only one carrying an umbrella. It was sunny. There was a 30% chance of rain at 2 o'clock. But I said, I'm wearing a suit, so I better bring my umbrella because I don't want to take the chance at 30%. And it turns out it started raining even sooner. Okay? So what threshold makes you carry the umbrella? What are personal factors that make you carry the umbrella? If I was wearing jeans and a t-shirt, I might not have bothered, but I didn't want to ruin my suit. And then how do you know your results are correct? It's certainly it's more of a rhetorical question because it's a very, very hard question and it varies depending on the situation. So when we think about data substrate, often in informatics, we're talking a lot now about big data analytics. This is high volume, high velocity of data that's sensibly related to the disease of interest. And I've seen and I've worked on projects looking at EEG data to find specific epileptiform patterns, image data to find lesions, sound data to detect important clinical findings like wheezing or murmurs. You can look at motion sensing to detect physical activity and suboptimal posture and apnea. These are continuous markers, high velocity, high volume data. But do you have high confidence in the gold standard? Even like telemetry monitors, when the alarm goes off on your continuous telemetry, is it serious? It's the gold standard for an arrhythmia on those telemetry alarms good. And again, do the findings support a clinical decision? The answer is sometimes. Now, my type of data sources, I'm a little more old-fashioned. I deal in the clinical administrative data collected through the routine operation of the health system. So visits and missed visits, an often overlooked thing. We all, we care about, well, what are the visit diagnoses? No, wait a sec, step back. Did the patient even show up for the visit? What is their show rate? Because that is a marker of health behavior that may be predictive of other things. If they show up, you get the vital signs, you get labs, and ancillary studies like pulmonary function tests, echo results, radiology results, and so on. Meds prescribed, meds picked up, meds taken, obviously very different. Diagnoses that get assigned, procedures that get performed, NLP stuff, looking at clinic notes and other narratives, social history like smoking, and telemetry monitoring, the other continuous stuff. My data, as opposed to other big data sources, is sparse. It's non-continuous. It's systematically and non-systematically missing data. There are temporal patterns in the data that mean regardless of the results may, but not necessarily be associated with an outcome. In other words, a patient who is showing up, I don't care why, once a year, okay, is suddenly showing up 3 times in a month and then goes back to once a year. That 3 times in a month, I don't care what's going on. I mean, I do care, but just the fact that they showed up 3 times in a month, it makes you expect things differently. I can't tell you how many times I've seen as a clinician, a patient I haven't seen in ages, like more than a year. I saw them regularly. I didn't see them for a couple of years, 2 or 3 years, and then they come back. How you doing? I'm fine. What brings you here today? Oh, my wife thought I needed a checkup. How are you feeling? I feel great. Anything going on? No. That guy is scared about something. Something prompted him to show up to the doctor after 3 years. Okay, and even if I don't notice anything, his exam is fine. I am humbled again by the number of times someone I haven't seen in a while shows up, they look good, and then something terrible happens shortly thereafter. It's a predictor just in the temporal patterns. We have disagreement about the presence, absence, or even the nature of an outcome. All right, who did this patient really have diabetes or asthma or COPD? I'll be talking a little bit more about this in a bit, but there's a lot more overlap in some of these things than most people appreciate. And then I haven't seen the machine learning algorithms that account for all this variability in the raw clinical data. okay? So the times, you know, all the data has been changing for some time. Electronic health records have been around for a long time, but still the data hasn't been good. But there are some national events that are changing the rigor with which data is recorded, and meaningful use is a big one. You put the incentive stuff aside and all of the things that people critique it for, it does enable better and more complete capture of information. The fact that we have to e-prescribe has been great. The fact that we're incentivized for making sure our patients with cardiac disease are receiving an aspirin, that makes me record aspirin even though it's an over-the-counter drug. But it's imperfect because even though the meaningful use requires that the prescriptions, the orders go to the pharmacy, the discontinuations don't always go to the pharmacy, and that creates certain issues. Changing paradigms for reimbursement are driving creative applications, favoring health information exchange, which again creates more good data substrate. There's more data on more patients than ever before. And clinical guidelines are another thing that are touted as good. I find them a little bit mixed for analytics, because in the old days, if a doctor ordered something like a lactic acid, right? Who gets a lactic acid ordered? A healthy person or a sick person? Give you a hint, a sick person, okay? But now if I have guidelines saying that anyone whose heart rate is a little fast and you know, they have a slight temperature and their blood pressure is a little low, they may have sepsis. And now if they're a little off, even if they look okay, everyone gets a lactate. And suddenly the value of lactate in predicting who the doctor thought was sicker than most is lost. So I think guidelines may be good for healthcare. They're not necessarily good for analytics. So let's talk about accuracy, because that's what everyone says. You know, if the billing data, which is the classic source, is so inaccurate, you can't use it for research. And a lot of people believe this, and I kind of believe it, but I'm a little softer. I say if you alter your notion that a billing code is the patient definitely has this disease to the patient has something like the disease, or the doctor is worried about the disease, and incorporate that ambiguity into your analyses, you'll be much happier. I think, but I'm not smart enough to know, I think that means I am a Bayesian at heart. Okay, there are frequentists and then there are Bayesian. I think I fall more in the Bayesian camp. And I encourage you to embrace the ambiguity and the heterogeneity in the billing data and elsewhere. So other things that there are a lot of assumptions made. Simple query tools, you've seen them. Vendors have tried to sell them to you and tout them as being excellent. And they're usually self-service tools that show dashboards and enable, you know, unsophisticated end users to perform high-level analyses is a good thing. The problem is that the high-level investigators and administrators don't have time or interest in doing these independent explorations. Some do, but most do not. However, if you create a good dashboard with one of these tools, uniformly, administrators like dashboards, just the way it is. I still like these tools. They're not necessarily worth $1 million that some of them are being charged for, but a good self-service tool will raise the basic understanding of data by an end user that increases the sophistication of the query posed, but there's still plenty of hopefully more worthwhile work to do by a team of you know, well-trained data analysts. It's sort of like the question, does a GI doc have to do every endoscopy? Okay, maybe, and that's debatable, but a lot of the endoscopies they do, maybe someone else could have done. But when there's an emergency, you want the endoscopist there. And I kind of feel the same way about informatics and data analytics. Study feasibility, this gets into the MOC questions. If I look retrospectively at observational data and I find that X patients with acute disease Y over time period Z in the past, I can expect to enroll X patients with disease Y over time period Z in the future. And that is not quite true, not because there are big shifts in the rates of these diseases, but your ability to recognize patients retrospectively doesn't mean you could recognize patients prospectively, which is often what's called for in these clinical trials. Like in sepsis, you don't want to, it doesn't matter how many patients with sepsis were discharged from your hospital. How many patients, have sepsis at a point where they can actually receive this drug at a point where it's going to do something? And pharmaceutical companies have been failing at that for my whole career, starting with Centocor way back in the early 90s. Another one, if I need to program my database query tool with all inclusion and exclusion criteria to assess study feasibility. I've seen some very high-priced consultants who say, here's your, give me all your inclusion exclusion criteria, and they run the numbers and they say, you have 10 patients, you can enroll 10 patients in that study. And then you look at the attrition tables about how many patients you started with, how many patients were lost at each, as you added each criteria. And what they forgot to realize is it's okay sometimes to play the odds. And if your study wants people to be HIV negative, since HIV, terrible disease, but thankfully relatively rare, chances are if you enroll 100 patients with other criteria, they're going to be HIV negative. You can make HIV testing part of the early recruitment process, but if you had 100 patients and you wanted those who are definitively negative, out of 100 patients, many patients, although the requirements for HIV testing are changing, many patients haven't even been tested, and the few that are, some are going to be positive, but most are going to be negative. So out of 100 patients, you might find only 5 patients who are definitively HIV negative, even though 95 of them are actually HIV negative. Reporting results. This is another biggie. There's some belief that when you report observational analyses that they should look like clinical trials results. And I disagree wholeheartedly because at best, this ignores the robustness and richness of the data and these alternative findings that you can generate under different assumptions, different subsets of the data you're looking at. And as a result, at best, your results may be spuriously favorable or not favorable, depending on how you chose to slice the data. At worst, the person who did this analysis actually did 10 different analyses, and they only reported the one that worked. All right? So I strongly believe we should be reporting multiple iterations of analyses of observational data. And this is a lesson in humility, ladies and gentlemen. In British Medical Journal and the British Journal of Clinical Pharmacology, in the same month, were 2 observational analyses looking at the use of pioglitazone. One of them concluded there was an increased risk of bladder cancer. One of them said there was not an increased risk of bladder cancer. Same month in 2 different British journals. You say, oh, that would never happen in this country. Well, it has. 1 year apart in JAMA, April 2012, patients taking oral fluoroquinolones were at higher risk of developing a retinal detachment. December 2013, oral fluoroquinolone use was not associated with increased risk of retinal detachment. Okay? Remember what I said at the start, our hormone replacement therapy, is it good or bad? As of yesterday, it's good again, yay, all right? This stuff happens all the time. What is the truth? So red flags. Show me an investigator that comes to the informatician looking for patients to enroll after a study protocol is written, and I'll show you a study that is doomed to fail. I think there's a general acceptance that people need to consult with a statistician during study planning. I strongly believe that you also need to consult with the informatician/data analyst early in the process. And then if you are a data analyst, study feasibility requires more than asking the investigator about diagnosis codes. Okay, I need a study of heart attack. Oh, what are the codes for heart attack? What are the codes for asthma? We all do it, but it's more than that. If that's all you're doing, I encourage you to delve into biology and clinical medicine a little bit more. Work hard with investigators to create a thorough computable phenotype for the condition of interest. All right? An investigator can't say what diagnoses are important until they see at least a frequency count of relevant diagnoses. Okay, and the investigator is not going to be familiar with all of the relevant diagnoses. And in the world of ICD-10, I was a master of ICD-9, but I'm not quite sure what's popular and what's more meaningful in the ICD-10 world yet. And then also, not all patients should be found through diagnosis codes. Lab and medication criteria are often helpful as well. So back to data accuracy. If accuracy is the truth, then that means if the data says they have asthma, then the patient has asthma. But if obviously the data that you're looking at is only as good as the information that was recorded. But if accuracy is a true representation of the source data, that means if the patient has asthma, then there's stuff in the database that's suggestive of the patient having asthma, and stuff consistent with asthma. Now, when I was in medical school, I was taught very explicitly by Ray Panettiere that you can either have asthma or COPD. You cannot have both. I know that's changing now, and there's an overlap syndrome. But asthma, to me, is a condition of reversible airways disease, and COPD is irreversible airways disease. So if you had asthma as a kid and you smoked a lot, and now you're older and you still can't breathe and you have irreversible airways disease, I call that COPD. But if you look in your databases, you will undoubtedly see people who have both asthma and COPD, okay? So clinical data is used in real clinical practice, so if doctors are using it to take care of patients, it must be accurate, but there are communication issues between the patient and the doctor, so not everything gets communicated properly. Busy doctors, we don't record everything properly. There are idiosyncrasies in the clinical setting in which data are collected. There's ambiguity inherent in the practice of medicine. I cannot overstate that. And then there's this notion of code creep, which is defined as early codes before a diagnosis of something like a cholecystitis. When did the cholecystitis begin? When the patient showed up to the ED with acute cholecystitis, or was it going on when the patient was presenting to their ambulatory doc with less specific abdominal pain? So the diagnoses may have been increasing in intensity, but the cholecystitis was definitely there before cholecystitis appeared in the record. Another definition of code creep has to do with the things that influence doctors' decisions to record certain diagnoses. So if a patient came to me with an upper respiratory infection is usually viral. So if I prescribe antibiotics and I use the term upper respiratory infections, I'm going to get in trouble. So maybe if you have a really bad cough and it kind of hurts in your chest, I'm not just going to label you with an and you really want and need antibiotics, I'm not going to label you with an upper respiratory infection. I'm going to say you have bronchitis. But actually, 90% of bronchitis is viral. So maybe, your ear hurts a little, maybe you have a little ear infection, or gosh, maybe you have pneumonia, you have walking pneumonia. And I know some doctors who do this, and the code creep is not so much with the patient severity, it's really just to justify the use of antibiotics. And I don't cross that line because in my heart, I know from folks like Jim Henson and others that a pneumonia carries with it a non-insignificant risk of death that is out there. So if I hear someone has pneumonia, I don't treat that cavalierly. And I have some friends and neighbors who said, oh yeah, the doctor gave me some Zithromax because he thought I had pneumonia. I don't like that because it's scary. But again, it's different styles, unfortunately. Research using billing and even EHR data must account for all the realities inherent in the other underlying data. So a little soundbite is absence of evidence is not evidence of absence. Just because you don't see something there doesn't mean it isn't there. Okay, there's a lot of depression in the community that unless you really probe for, you're not going to be aware of it, and then it doesn't get recorded. Vigilance in exploring for a condition, even if it turns out not to be present, has clinical relevance. In other words, I listen to everyone's heart and lungs all the time, okay? But I listen more closely if the patient tells me they're short of breath, or if I notice their legs are swelling. So I'm more likely to pick up a murmur, which makes me more likely to send them for an echo, not because of any, just because of something I observed. And even if that echo comes back negative, I observed something that probed me, that motivated me to get the echo. Clusters of visits are significant but not necessarily directly related to the clinical condition being studied. This can create a paradox where a sick patient could look healthier than a healthier patient. Case in point, 2 patients walk into my office today. One of them really sick, has a lot of things going on. One of the problems is high cholesterol. I say, okay, you gotta get started on this cholesterol medicine, and let's see you back in 3 months because I'm really worried about all these other things. Second patient, really healthy guy, once-a-year patient, but I notice his cholesterol's a little high. I start the cholesterol medicine today, and I say, you're healthy. I could see you back soon, but I think you're going to do okay. Just come back in a year. We'll retest your cholesterol then. So now the sick patient comes back in 3 months. I test his cholesterol. Let's say, for argument's sake, that he's compliant. And I test his cholesterol, and the cholesterol's improved. Yay! Then my healthy patient comes back in a year. He's been compliant. I test his cholesterol. It comes back improved. Yay! Okay, so now if you look at the data, how soon did the first patient, did it take for that first patient's cholesterol to improve? 3 months. How long did it take the second patient's cholesterol to improve? A year. Now, clearly, when I say it this way, you know that probably if you tested the healthier patient's cholesterol sooner, their cholesterol would have been better sooner. But I can't tell you how many times I've seen people oversimplify and just use the timing of the improved cholesterol as when they got better. And you just can't do that. I was alluding to this before. You need to consider all the ways a disease may be represented in the diagnosis codes and ancillary test results. So because of this, you cannot look in administrative or even EHR data for upper respiratory infection because you're going to get a biased subset of people with a sore throat. You have to look at the people with respiratory conditions. URI, bronchitis, tracheitis, pharyngitis, sinusitis, clinically are harder to reliably distinguish, especially empirically, than most people would like to think. The things we've often heard where green sputum is bacterial and yellow sputum is viral is not true. And broad definitions must be considered in the assessment of both risks and outcomes. We need to think about censoring issues, and we adjust for these things statistically, but I think some of the problems go beyond what can be adjusted for in censoring. So left censoring is that the first instance a condition appears in your data isn't necessarily when the condition first appeared. And then, as I said before, absence of evidence is not evidence of absence. On the right censoring side, data must cover a time interval long enough for the exposure to result in an outcome that is captured in the data. So if you want to look at smoking and cancer, and you only have 1 year of data, I don't care how much right censoring adjustment you do, you're going to miss some of the risk because in a 1 year time period, most people aren't going to develop cancer. And if you have 1,000 patients studied for 1 year, that's 1,000 patient years. If you have 100 patients studied for 10 years, that's 1,000 patient years. So when you see patient years, you assume they're the same, but I believe those two scenarios are very, very different. We need to worry about data from uncaptured clinical settings. You get your angioplasty at the big inner city hospital, but when you have your GI bleed, you get hospitalized in your local community hospital. So if you're not capturing that, the insurance data to know that, you may assume that your patients are doing very well post-angioplasty when a lot of them are having GI bleeds. There can be logical inconsistencies. I see patients at Temple, some of whom I used to see at Penn. At Penn, they had certain allergies recorded. At Temple, not, or vice versa. And they've been receiving prescriptions at Temple, and they're doing fine. And at Penn, they have an allergy listed. So which is correct? Another big one that we're a little ashamed to admit are other temporal issues. Oftentimes, we doctors only hear the heart murmur after the echo reports mitral regurg. Sad but true. If the cardiologist heard an S4, I hear an S4. I never do that, but it's out there. It's done. Another one is heart failure can look like it's caused by an ACE inhibitor because only the patients who receive ACE inhibitors have heart failure. But in fact, the ACE inhibitors, which are medicines for blood pressure, the presence of heart failure is a compelling indication to choose ACE inhibitors, and unless you know that, you might reach some incorrect conclusions. Uncoded information, the so-called institutional metadata. You may think that there's an epidemic of certain conditions in certain parts of your hospital, but unless you know that, these rooms are the isolation rooms, or these rooms are close to the nursing station and they go out of their way to put their sicker patients near the nursing station, you may reach some bad conclusions. So you have to know this stuff as well. And there are regional and personal variations in documentation style. I know among pediatricians, do you like to tell the parents of the kids that they have asthma, or do you say they have bronchospasm? Asthma's scary, bronchospasm's less scary, right? So it's out there. There's treatment bias. Medications are prescribed because the provider believes the patient needs them. And sicker patients may systematically receive certain types of medicine more than others. There are testing biases where patients who test positive for certain tests are more likely to receive additional testing, related or unrelated. There are formulary issues. Insurer rules can limit the use of certain medicines to patients who've already failed other medicines. And you know something? In the clinical trial, they tested those medicines head to head, and the new medicine was a little better. But in practice, they're only giving the medicines to people who failed the first medicine. And I can guarantee you, if you failed the first medicine and then try the medicine that was okay in a head-to-head comparison, it's probably not going to perform as well if every patient receiving it has already failed the first medicine. And this affects the phase 4 real-world clinical trials. There are practice variations. Some medicines are favored in different institutions for different non-clinical issues. And there's a big problem with over-the-counter medicines like aspirin, other nonsteroidals, and proton pump inhibitors. In the old days, everyone who received omeprazole needed a prescription for omeprazole. Now you can just sort of pick it up in the CVS and not tell anyone. So how are you going to look at the impact of aspirin or any of the NOACs on GI bleed if you don't know who's taking an anti-ulcer medicine? You can know these things, but it's a little more challenging these days. So we try to correct for some of these problems, but in coming up with ways to correct for these problems, we introduce other biases. So if your definition of congestive heart failure is echocardiogram demonstrated congestive heart failure, you need to appreciate the fact that even if, I alluded to this before, even if you have a good ejection fraction on the echocardiogram, so they're in the non-CHF category, that patient probably has something CHF-like that someone who's never received an echocardiogram doesn't have. For the incident case thing, like I said, if you assume the patient's first diagnosis of diabetes is the date they started having diabetes, you're going to be wrong a lot of the time. So what you can do is look for patients who've had a string of visits without any diabetes diagnosis recorded, and then after a year or two, suddenly a diabetes diagnosis appears, you might more correctly assume that that is an incident case of diabetes. But the problem is that means you've only included people who've had other visits with a certain frequency and pattern, and that patient may be, they may have an incident case of diabetes that you're looking for, but they may also have greater comorbidities that can impact their response to treatment or whatever else you're measuring. You may want to integrate more databases, another MOC question. Let's get the databases from CHOP and Penn and Temple and Jeff and merge them all together. And we could just do that, and we have all this NLP, we can merge, do probabilistic matching of demographics, and that's going to be great. And it is great, but it's not out-of-the-box solution because you will find clinical conflicts in data for the same individual. And then furthermore, if you can't identify patients across different systems, you will double count people. So if you're known as John Smith at Temple, but at Penn you're John Smith Wilson, and they don't match, and maybe there's a typo in your birth date, and John Smith has a heart attack at at Temple, heart attack at Penn, it'll look like two different people rather than the same person with one heart attack, and that's bad. Another informatics buzzword is semantic interoperability. If we only had semantic interoperability in HL7 version 3, we would be able to communicate unambiguously. But in reality, have you ever seen two doctors agree on anything? Right? You're all hearing my words and you're all interpreting what I'm saying a little bit differently. So if you're expecting the computer to magically create interoperability when that interoperability doesn't exist between two human beings, that may be a stretch. Standards. Yes, standards will enable computer systems to share a common language to describe clinical concepts. Yes, if we all used RxNorm and SNOMED and ICD-10 is so much better than ICD-9. But what I see in these vocabularies is sometimes, or oftentimes actually, the precision in the vocabulary exceeds the precision of medicine. When I'm seeing a patient and I'm trying to type in they have BPH, the computer's saying, well, is it nodular or non-nodular? Well, I don't know. They have symptoms of BPH. So if you force me to pick something, I'll pick something, but please, I want to be able to say non-specified or unspecified because I honestly don't know. The universal identifier problem for identifying individuals across systems will be solved with better algorithms, so we can match John Smith at Temple with John Smith Wilson at Penn. And things are getting a little better, but the state of the science now really requires not only the individual patients, but all of their family members as well. Automated business rules will help manage updates to data. So if an address changes, is the old address wrong or did the patient move? That information's often not recorded. What if a gender category changes? Even if you're sure an earlier record is an error, should that record be removed from the warehouse? The warehouse is a great place. How many women have prostate cancer? How many men have had ovarian cancer? You can see those things, you can correct them in the warehouse, but shouldn't you be correcting them in the source data? And what you use kind of depends on the nature of the analysis you are doing. A risk adjustment should require the true data, but sometimes you're just evaluating a decision support system, and then the issue is more based on what data was available at the time. So a lot of this stuff was finally published in Medical Care way back in 2013. So there's a lot of cool stuff in here that I've said and some things that I haven't said. I encourage you to look up that article. And I just want to close with a few slides about deriving truth from appropriate application of research informatics methods. This is why we're all in this business. So understand what you can and cannot expect from observational data. I've worked with the big data vendors, Optum and the one that just got bought by IBM. And there are a number of these big data vendors that will tout their millions of lives and multiple years of overall data. It doesn't mean that individuals in that database have been followed long enough for you to assess outcomes. And I alluded to this before with the 1,000 patient years. Big data does not always mean representative data. Okay, you can have a big population in central Pennsylvania, but that won't always apply to Philadelphia. Okay, and results of analyses are supposed to provide a broad set of answers under different assumptions of the definition of who is exposed and the complex nature of an exposure in the real world and what the outcomes are. Okay, observational analyses are supposed to have diverse answers under different assumptions. It's great when you do all these analyses and everything agrees. And if it doesn't agree, you got a little more work to do. Better accuracy than humans, or the ability to augment human assessment, is a great goal, but be mindful of what can be done with the improved knowledge that is gained. All right, and this is me being a little old-fashioned here with my stance on genome-guided therapy. I love truly precise genomic-guided therapy. I think it's great that in patients with cancer, you can do a genomic analysis that tells you with great certainty that choosing this chemotherapy regimen is better than choosing that chemotherapy regimen. I hate to say hate, but I hate imperfect risk prediction of diseases that have no adequate treatment. So that thing that tells me that I have a 60% chance of getting Huntington's chorea in 30 years is not helpful. Some of what 23andMe does is helpful. Some of what 23andMe does is not helpful. For you big data people in the crowd, beware the impact of heterogeneity that exists within members of the same cluster. All right, cluster analysis is good. It shows you people who are sort of like each other, but there's still heterogeneity. And don't let yourself be surprised by that. Be mindful of a tarnished gold standard in your classification analyses. Okay, you're going to classify people as definitely having gout and definitely not having gout, definitely having lupus, definitely not having lupus, rheumatoid arthritis. Not all diseases are equally separated as haves and have-nots. And please, 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 it's only data, no one gets hurt. But never forget that there are real people underlying the data you use and who are impacted by your findings. So yes, the retrospective data analyses especially, they go through expedited IRB approval, but always have great respect. Some people literally died in order to provide you the data that you're using in your analysis. So please respect that. And I will close there and take questions.